My name is Kim Hye Ryun, an assistant professor for Yonsei Cancer Center Department of Oncology. Today, we are going to discuss data sharing methods related to therapeutic reactivity of cancer immunotherapy and the kit for practical use. As for recurrent or metastatic non-small cell lung cancer, PD-1 and PD-L1 inhibitors, or in brand name, Keytruda, Opdivo, and Tecentriq, are now the standard of care. There are less number of predictive biomarkers than there should be, however, in regards to therapeutic efficacy of PD-1. In fact, PD-L1 expression rate in tumors or immune cells is the sole and only viable predictive biomarker. We check that rate in the pre-treatment screening, as you know. Also to note is, assessing PD-L1 expression rate from immunohistochemical standpoint is not as accurate as it should be. Therefore, viability of using PD-1 inhibitor in NSCLC patients and improving therapeutic efficacy thereof may only be secured with development of more accurate predictive biomarkers. Among others, a biomarker would be considered ideal if less invasive and easily developable, in which case blood biomarker is a likely type of predictive biomarkers that should be developed. Blood biomarker as a predictive biomarker of PD-1 expression is rather deficient, however. NSCLC patients have immune cells, cytokines, and chemokines in their blood, where they are possible biomarker to assess viability of cancer immunotherapy and the key factors of controlling tumor immune microenvironment. Let me just share with you some difficulties of clinically using PD-1 inhibitors as a standard therapy. The case is a male, 43-year-old, stage 4 NSCLC patient. His initial use of PD-1 inhibitor took place on April 2016 and had no 0% PD-L1 expression, which is the predictive biomarker. He actually, as you can see, had enlarged lymph nodes with pleural effusion that led to severe dyspnea, but has successfully retaining good condition since being cured by using PD-1 inhibitor 2 years ago. The above case signifies that PD-L1 inhibitor may possibly work in patients with no predictive biomarker measured. Chances are, in some patients, PD-L1, the one and only FDA-approved predictive biomarker, is not viable, while there exist medical needs in such patients for sure. This is the second case where PD-L1 expression was measured at 90% and tested strong positive, and ended up the cancer being aggravated soon after receiving doses. No therapeutic response was observed while progressing cancer at a faster rate. The case strongly backs the idea that in some patients with high PD-L1 expression, use of the inhibitor may not be as effective in clinical settings. This is why we're in dire need of an accurate biomarker that is more accurate and viable than PD-L1 expression to maximize the therapeutic effect in broader scope of patients, taking into account the unmet medical need. It is also to note that Keytruda and Opdivo ranked number 1 and number 4 in the projected top 10 most sold drugs across the world in 2025. Taking into account that the PD-1 inhibitors are an FDA-approved therapy in a variety of cancer types, including NSCLC, evidencing strong market value. It is even more important for all of us to have a predictive biomarker that is so viable as to use PD-1 inhibitors selectively to patients that best suit and in avoidance of adverse reactions. Among a variety of predictive biomarkers for immune responses there is, as we all know, PD-L1 expression, which is a tumor marker expressed in tumors or immune cells. In terms of mutation, there is another highly viable predictive biomarker to decide use of PD-1, that is tumor mutation burden. Inflammatory gene is also worth a mention as it gains interest in recent days. In the red circle, in terms of immune system level, there are a number of blood biomarkers such as a variety of biomarkers out of the patient's peripheral blood that are referred to when deciding to use PD-1 or not. These viable candidate biomarkers are under research. So, let me share with you how we schemed out of the study to develop predictive biomarkers to decide use of anti-PD-1 therapy. Doing so, we have collected plasmas off the patients receiving PD-1 inhibitors before and after the therapeutic use, and seen how cytokines and PBMCs vary after the initial therapeutic cycle. Followed by that was FAKES analysis to analyze in a broader scope immune cell types, and a variety of investigations using cell-suppressive markers. Analyzed doing so were, among others, CD4 cells, CD8 cells, regulatory T cells, and last but not least, MDSCs being one of the most known suppressive cells. Among those MDSCs, we've analyzed the monocyte-derived MMDSC, and among other PMN MDSCs known to specifically suppressive in cancer patient, LOX1 positive PMN MDSC, where LOX1 is a marker for multicolor FAKES analysis. One more thing to note is that we've worked bioplex as a protein-level means of analysis for both cytokines and chemokines in the patient's plasma for about 40 immune-related markers. Before and after the therapeutic use of PD-1 inhibitor. We've worked correlative analysis for markers in patients expressing any treatment outcome, in patients expressing early response, and in patients with no therapeutic response to develop the eventual biomarkers that work. According to the summary, we've worked the study in about 100 different patients, and the correlative analysis of results out of discovery set and results out of validation set where the biomarkers derived out of the discovery set was verified in validation set samples. Like I said, we've worked analysis of both PMBC and cytokine level before and after the therapeutic use, where comparison of the on-treatment biopsy results before and after the therapeutic use resulted an inverse correlation between the ratio of regulatory T cells that is known to be more suppressive than other CD45 positive lymphocytes and the ratio of actual LOX1 positive and PMN MDSC positive cases among other CD45 positive lymphocytes. And when it comes to biomarker development, we took into account the ratio as above to determine the cutoff level of response group and, on the polar opposite, non-response group. Comparison between the ratio of Treg and the ratio of actual LOX1 positive and PMN MDSC in response group and non-response group after the initial therapeutic use resulted in statistically significant increase in response group in both ratios. On the ROC curve, the result comes up with the cutoff level of 0.39 for both ratios, for significance in AUC level at around 0.86. Statistical significance was also observed in extension of progression-free survival in patients on the blue curve compared to the yellow curve patients. To develop such data into a viable predictive biomarker, we've used independent validation set to see if the response can effectively be predicted in either group where TMR, Treg, LOX1, or PMN MDSC ratio exceeds 0.39. After the initial therapeutic use, we've made sure that groups with TMR ratio exceeding 0.39 expressed larger response, with the same result observed in the discovery set. With the above being said, We now understand progression-free survival increases with significance in the patients on the blue curve, meaning the patients with TMR ratio exceeding 0.39. This means a lot in that a mere therapeutic cycle of using PD-1 inhibitor just suffices to predict response, a significant improvement from the conventional 4 therapeutic cycles. So, with the highly viable predictive marker like this, patients may receive blood tests after the initial therapeutic use to get TMR outcome, which is the treatment outcome, meaning that TMR ratio is a viable on-treatment biomarker for PD-1 inhibitor therapy. On to the next we go. We've compared performances between 2 different predictive biomarkers, the conventional PD-L1 expression and the newly developed TMR ratio, where the conventional PD-L1 expression is observed in terms of IHC level in pre-treatment phase. Doing so, we've drawn comparison between positive predictive values and negative predictive values, where we've observed positive predictive values in 40% of the PD-L1 positive patients and in 69% of the patients with TMR ratio exceeding 0.39. In terms of negative predictive value, we've observed negative predictive values in 69% of the PD-L1 negative patients and in 90% of the patients with TMR ratio exceeding 0.39, also implying advanced performance of TMR ratio as an effective predictive marker compared to the conventional PD-L1 expression. Same result on the ROC curve here, as the percentage was 87% for TMR ratio, significantly higher than 57% for PD-L1 expression. With certain group of patients where the percentage is 90% for PD-L1 expression, even failing to respond to therapeutic use of PD-1 inhibitor, the above result means a lot, in that PD-L1 expression is a potentially reliable predictive biomarker to assess feasibility of early response in patients where PD-L1 expression is not a reliable predictive biomarker. The other way round, in patients where the percentage is 0% for PD-L1 expression, but 1.0% for TMR ratio exceeding 0.39, it is to say that TMR ratio may serve as a predictive biomarker of feasibility of early response and is worth further development to supplement the conventional PD-L1 expression. So far, we've discussed that TMR ratio, more specifically TMR ratio exceeding 0.39, is an efficient, reliable, on-treatment biomarker in patients where PD-L1 expression is not a viable biomarker, as the TMR ratio is accessible right after the initial therapeutic cycle. We've also discussed the possibility of cytokine and chemokine levels assessed in the patient's plasma or serum replacing PBMC or other cell markers, and their relationship with the clinical response in use of PD-1 inhibitor in clinical settings. As for the biomarker's feasibility as a pre-treatment predictor, we've worked a couple analyses, the first being verification of about 40 immune-related markers such as cytokines IL-6 and IL-8 and chemokines CXC3CL1 and S100A8A9, where these cytokines and chemokines are related to the response rate of PD-1 inhibitor therapy, and high IL-6 level leads to lower response rate. With the rest, IL-8, CXC3CL1, and S100A8A9 expressed at a higher rate in non-response group compared to response group, like what we previously saw on ROC curve. And next, we've drawn comparison between performances of PD-L1 expression and TMR ratio to demonstrate the TMR ratio's advanced feasibility of being used as a predictive biomarker, as the positive predictive value exceeded 70% when chemokine level was low, meaning that TMR ratio can be an effective, viable biomarker of assessing from the baseline the feasibility of therapeutic use of PD-1 inhibitor. In a nutshell, it can be said that TMR ratio is non-inferior to the conventional PD-L1 expression. With all of the above results drawn out of Bioplex, it has more room to develop in that, for the biomarker to be used in clinical settings, the easy-to-use kit like ELISA is in need, which is what we're also working on. In conclusion, with development of blood biomarker more accessible compared to that of tissue biomarker, we've seen the potential of not only TMR ratio, but also Treg and MDSC ratio as a viable on-treatment biomarker of early response in long-term use of PD-1 inhibitor, as well as the relevance of some 4 cytokines and chemokines to the response rate of PD-1 inhibitor, implying their potential of being used as viable blood biomarkers. Thank you.